Yeah, when we're thinking about treatment with single-agent anti-CD20 antibodies such as rituximab versus chemoimmunotherapy approaches such as bendamustine rituximab or R-CHOP, we really, in my practice, I really look at whether or not the patient is symptomatic, what are their comorbidities, and frequently, what are their treatment goals? Are they wanting to avoid more aggressive regimens and really make it a patient-centered decision? I'll feel much more comfortable if they are older and have more comorbidities to back off and use just single-agent anti-CD20 therapy. Additionally, if they have low burden but are somewhat symptomatic and we're potentially trying to prevent needing to use more chemoimmunotherapy, if we were to just simply observe and a lymph node were to grow to be bulkier, more than 5 centimeters, closer to 7 centimeters, things along those lines, I may decide to treat with anti-CD20 to try to capture the patient in a low tumor burden situation. When a patient is symptomatic, when they have bulky adenopathy, when they are in need of a response that is that's going to be more rapid and durable, that's where we start to think of our chemoimmunotherapy options. So when we're looking at which type of anti-CD20 therapy we want to utilize, we are now fortunate to have several antibodies that are currently FDA approved for different indications. While there's not currently FDA approval for drugs, third generation antibodies such as obinutuzumab, we are able to access these drugs because the marginal zone lymphomas have been studied in randomized phase 3 protocols. And so in an upfront setting, typically I don't use obinutuzumab. I'll typically use rituximab. But in a second-line setting or in any patient that demonstrates that they are rituximab refractory is where I will employ going to what are potentially considered better antibodies or more effective antibodies and using obinutuzumab.